Hello, my name is Jeff Hauk from George Fox University, and I'm here to present the 50-50 lecture series where we discuss how performance and behavior change are 50% physical and 50% psychosocial. This is sponsored by the Beyond Biopsychosocial Learning Platform at beyondbiopsychosocial.com. So I want to talk about a study today that I performed with two psychologists, interns from George Fox University, and it stems from my motivations to do better outcomes in the biopsychosocial model. When I was asking therapists about using the PROMIS measures that can measure psychosocial variables, they said, why do we need those? We're already psychosocial. And that really stumped me because I thought, how can people have so much confidence in being psychosocial when they haven't really had that much training or assessed their skills in psychosocial care? And so, but I kept running into this roadblock. And so I decided, what if we just observe people? Because, people have good intentions and they want to be psychosocial, but are they really psychosocial? And so Dr. Gildenhouse and Dr. Wang, Fred and Sally, were two psychology interns, and they wanted to work on a project with physical therapy. So we decided to look for an observation form that depended on direct observation of psychosocial skills that had been spelled out by an important body. And essentially the Kalamazoo Conference came up with an essential statement with participants focused in this conference on delineating a coherent set of essential elements in the physician's patient communication. And based on that, this patient-centered observation form had been developed and been widely used in training to mentor new medical physicians. And so what we decided to do is adopt that questionnaire or direct observation form. And Fred and Sally did the legwork in terms of going and visiting 21 therapists during 48 encounters, and completing the PCOF during the encounter, and also asking the providers to fill out a physician belief scale where they were assessed on their strength of beliefs in biomedical versus psychosocial factors as the cause of disease. What this allowed us to do was to separate the 21 providers into two separate groups and then look at their observations on these 10 categories in the PCOF form, which include rapport, maintains relationship throughout visits, collaborative upfront agenda setting, maintains efficacy and out loud thinking, gathering information, which is basically motivational interviewing skills, exploring patient or family perspective on health, sharing information, behavior change, self-management, co-creating a plan, and closure. And you can see where the stars are is where, both groups did well. So in terms of rapport and maintains relationship throughout the visits, both the strong biomedical beliefs and those providers with strong psychosocial beliefs scored well in these areas, meaning they used communication skills that were considered essential. And then if we also look at the rest of the items, though, they almost all favored therapists that had strong psychosocial beliefs. So what this suggests is that not that you have to have strong psychosocial beliefs to use good collaborative communication skills or these ones that have been defined as essential, but it makes it more likely that you will, or that at least you're open to them. And so it gave us a starting point to talk to providers now about, okay, yes, some psychosocial skills we all have, rapport and maintaining relationships throughout visits. And you could see the behaviors there if you go to the PCOF form itself. But it also helped us understand that providers who are really invested in more of a psychosocial approach to care, what kind of communication skills they work on and develop. And so with that introduction, we're going to now cut to the interview with Dr. Wang and Dr. Gildenhouse. And then we've invited J.D. Romnick, a physical therapist at George Fox University who participated in the evaluation as a provider and was observed as part of the study, and what kinds of things came out of this assessment using the PCOF form. Thanks for being on the 50/50 podcast, you guys. This is so exciting because I've got a physical therapist who's amazing, JD, who has been amazing in terms of like both physical and just overall healthcare, physical therapy. So, and then 2 psychology internists that I've had the pleasure of meeting this last fall that have been working with me on a special project that I'm really happy about, and it's just their work has been really critical in it. And so Fred Wang, who's also a psychology intern, that have like essentially been looking at physical therapist encounters using something called the patient-centered observation form. And JD was one of the therapists that they assessed using this form. How long ago?
Oh man, probably a month or 2 ago, like within the last couple months.
Right.
Yeah.
And I really was interested in this because essentially it was anxiety provoking.
It was
right?
terrifying. If you want to get graded you're in school, you're getting graded like great, you know that you're getting grades for it, whatever. But now you're a professional and you're getting put on the spot. It's very terrifying. You want to make sure that you're doing the best job. You think you're doing great, and then
Well, I got graded today, and I could completely empathize with you because I couldn't keep it out of my mind that I was being graded and had to like try to perform. So I appreciate you volunteering and being here today. And then you guys had to learn how to use the patient-centered observation form, and then also learn about PT, and so how did that go? Like you.
I think I was excited at first. I'm really interested in the mind-body connections, and I think Fred's very interested in that as well, and he can speak to that. But that's been kind of my jam, and now I get to learn more about the body side of it, but then also how can we help each other and strengthen each other? Like, what is each of us bringing to the table? And for us, it was more about how we help you be more psychosocially oriented and come from our frame of reference. But then, maybe in the future, thinking about how can we have those roles reversed? How can you help us be more body aware? And
so now you want something back.
We already covered that.
You want some physical therapy skills.
Well, it's bi-directional learning, right?
Yeah.
So and actually, we've been learning so much simply by observing and watching how you work. What's the rhythm of how you work? What are you doing? We often don't even touch our patients, and that's such a huge part of your work, is touching people and kind of assessing what's happening within their body. The palpation, the range of motion work.
Right.
Very fascinating.
But you are here because you brought the interviewing skills and the psychological skills, the analytical, kind of skills of communicating and navigating communication sometimes, which can be difficult. Right? Perfect. So, Fred, how about you? Like, how was this experience, for you when you first got started?
I think in many ways it was something that I actually really do care about too. Sally alluded to it a little bit earlier, this idea of the mind and body being connected. And I think realistically in healthcare we've become so siloed, where there's the psychological side of things, there's a physical side of things, both with the primary care or with physical therapy, with nutrition. And oftentimes we don't really know what we all do. And sometimes we get these clients or these patients that are seeing a physical therapist or are seeing a nutritionist or dietitian. I don't really know what they're discussing, and I don't know how to help them with this.
And a good example would be like you do biofeedback EMG, and a PT would never know that, right? So you're looking at some physical responses right there, and Sally's talking about touching patients and doing that kind of thing, and so there's this question of when is that appropriate, not appropriate for either one of us to do, and then like what should we be doing in terms of psychological care, right? So there's 12 categories in the patient-centered observation form, and the problem with it is it was really developed for primary care, not physical therapists. So there's this question right now with this research as whether this form applies to PT in specific, and I think it does. And I think what we're going to hear right now is your opinions on how that would transfer. But, part of the motivation for this research was the idea that us as PTs, we think we're psychosocial. And we are, like, there isn't a PT out there that doesn't think that they're psychosocially focused and really care about patients' emotions as well as their social status and things like that, even if we are focused on physical health, right? We want that all to be integrated, right? And so what the question is then, if you are psychosocial focused, how do you self-critique? How do we evaluate ourselves? And so when we were all talking about this, you know, and trying to wonder how to do this, and we're kind of spinning our wheels this last fall, and then we hit on this patient-centered observation form that gave us really specific behaviors that providers display that reflect their psychosocial beliefs. And so we thought, well, these are kind of similar to what PTs might do, and then we went ahead and used it to test these encounters, and that's the centerpiece of the research, right? Here I want to highlight the strengths that physical therapists had, and you can see that we greeted patients warmly and really connected with them initially. That's just a rapport, and then we're able to maintain this relationship and empathy throughout the visit. And then finally, we really emphasized in this next section efficiency. So we were time efficient, managed time well, although we could have improved in this area on certain items. And then this next item, sharing information, we were passionate about education, but we tended to focus on biomedical and not psychosocial concerns. So that was identified by the PCOF categories. So in summary, what this showed is that we were good at rapport, we could maintain a relationship through empathy and pausing with the patient, that we also were time efficient in the communication skills that we used, and we were passionate about education. Let's hear about what else got discussed and how else we can improve. Right, so that's fantastic, right? And then the other thing that we were good at was really open-ended questions. Like, we really were really good at open-ended questions. Somehow we've gotten the word on that's a good thing to do, and so we use lots of open-ended questions, which I think is going to come out as an issue in terms of, because open-ended questions are good in terms they invite patients into the encounter, but they also make the encounters really long, right? And they make them like wander in different directions because we don't know how to focus the encounter, right? So it was good from a psychosocial standpoint, but it also needs to be coupled with other kind of interviewing or communication skills. Mm-hmm. Dr. Gildehouse. Yeah. So let's get into the things that we weren't good at, and then let's just hear whoever wants to start. Okay, so there we go. Behavior change, co-creating a plan, closure, and then I think collaborative agenda setting. Those are really the things that we have room to improve on. So let's hear maybe
I'd actually love to hear what they have to say about what they observed from PTs, because I know from being graded the things that I've improved on, and I mean, I'll let you guys grade me again. But honestly, it's been I've been focusing on it so hard. So you guys can tell.
I mean, I think if we were just going to start, just to jump in here, overall, I actually do feel like a lot of PTs used a lot of psychosocial interventions. At least they had the intention, and this came across pretty clearly in what we're doing. The areas where we did find that there was the most discrepancy, though, some were actually doing it really a lot more than others, really was in that collaborative piece. And genuinely speaking, I think a lot of that comes down to some of the earlier kind of communication styles that are happening in intervention that are not supporting it or not kind of getting to it quickly enough. I remember having a conversation with a PT following these interviews or these observations with them, where we were really just talking about the fact that to really get into that sort of co-creation of plan could take 20-30 minutes on its own if they're sitting there and not doing anything else, just debriefing from the
talk therapy, this idea of talk therapy, which a PT is like, what do you mean? Like, I have physical things to do with somebody. That's not going to get me a biological change, right?
And I have 30 minutes to do it.
Yeah, and so it's not realistic that that's really a good approach, right? So so what did you think?
I mean, I think what came out was a lot of these attempts to do a lot of these points that we were assessing for and looking at and researching. It almost kind of felt like there was this intense desire to do it, but it would kind of land flat or get halfway there and not quite get to the point. So
let me push you on that one, because I think I think one of the things I hear you saying just to kind of the subtext there is essentially we didn't have the skill to move the process of communication along, so we could actually do the co-creating and do the physical therapy that we wanted to do. We had the intent, but not the communication skill. Information section of the PCOF, which focuses on motivational interviewing skills, including open-ended questions, reflective statements, summaries, and how they can be used clinically. Is that true? And I think specifically this research identified what skills we lacked, right? And like and that had to do with the gathering information and this overemphasis on open-ended questions. So what's the skills we're missing there, like that you guys have studied for years how to do it? Like, what would you say are skills that we need to acquire to be efficient at this process?
There's another actual behavioral anchor on that form that talks about gentle redirection and interruptions. Using like 3 E's, it's like empathize, I can't remember the other 2 off the top of my head, but explain, and then if you notice that the conversation or the interventions are kind of digressing, then you can kind of redirect them, or you've asked this open-ended question, but it's kind of like ballooning into this whole different thing. Then you can say, I hear what you're saying, and that's really important. Let's come back to this thing that we're talking about today, and let's kind of keep this moving on track, because I know there are real time constraints on what people are able to do. So it's that visit efficiency piece as well, and open-ended questions push back visit efficiency. So it's that balancing act.
But your scoring on the efficiency was good, actually. That
it
part
was.
of it, nonverbal, verbal communication, and efficiency and interruption, we handled that pretty good.
Yeah.
But what about reflective statements and summaries?
Right, so that was the part where there could be maybe some more improvement that we weren't marking as much and not noticing, along with those gentle interruptions and redirecting patients when it seems like.
Let's be clear, about reflective statements and open-ended questions.
Okay.
They were almost never used, right?
Summary statements and reflective statements, right.
They were almost never used. It wasn't that they were underused, they were just absent because people were over-reliant on open-ended questions. So a reflection is a communication skill that gives the interview focus and moves the interpretation of what the patient is saying quickly to completion, right? It kind of keeps it. So in terms of speed, if you took your open-ended questions, decreased them, and increased your reflective statements and summaries, the speed of your interviewing and information gathering would increase dramatically.
It could, yeah. Just helps move thing along. Like, we wrapped up this one bit, now we're on to the next bit, kind of keeping that direction going, while also inviting the patient to buy into their treatment. Because oftentimes with PT, they're there because their doctor told them to be there.
Right.
And so how can I get this patient to buy into this experience and kind of invest and join me? And you're joining with them as well. So then there's that other bi-directional piece.
What's interesting, and I might add on to that, is because you brought up their doctor told them to be there. It's interesting because they still showed up. So for some people, their doctor tells them, but we I think have a hard time sometimes actually hearing what the patient's problem is. Because sometimes they will tell you if you dig deep enough, their doctor told them to come, but they may have this underlying fear that they may actually have a problem, or they may never be able to walk again. And it's interesting, I have students right now that I've been on them about the reflective statements, because that's a huge thing I took away from this experience, is that you have to be able to summarize and capture what the real concern is, because once you make those statements, you reflect, you make those summary statements, and you've challenged me hard on this, is instead of asking those open-ended questions, which we're really good at, making those reflective statements of saying, your knee hurts and you're really worried that you'll never be able to dance again. And they can confirm and say, yes, actually that's why I'm here. Whereas their doctor might have said, go see a PT, they might get you better, I'm going to send you to a PT. And they're here well, my doctor said, come get my knee stronger.
And the thing is, and oftentimes they're hedging on all this stuff. They're not really saying, I'm afraid I'll never be. They don't want to admit to that because it's kind of a deep, dark secret or something, right?
Yeah.
And then you're saying, okay, you're collecting all these cues, they're not putting weight on it. they've heard these negative, they've expressed negative thoughts, and then they're kind of, giving you some wincing or indications. So there's all these different signals, and so then you can go ahead and throw it out.
Yeah.
What I'm seeing is you may believe that something's really wrong with you, and you're not going to be able to get back to what you want to do.
Yeah.
And that statement there, then they can just say, no, I'm good, or they can say, yeah, that's exactly how I'm thinking,
Right,
and then
they feel
expand
seen.
on it.
Yeah.
And the most surprising thing, I think, to most PTs is that a statement rather than a question actually elicits more verbal response from the patient and more deeper kind of revelations from the patient. Like
Right.
they tell you stuff, right, that they haven't really. Hi, Dr. Kang. But they tell you stuff that they might not normally say, right? And then you're just like, wow, how did that work? Because I didn't even ask a question.
Right.
And they told me more in response to a statement where I just made it up about what I thought they were saying or interpreted it,
Yeah.
and then they came through with a lot more information. Is that something? Is that like a? Because that's like a secret. That's like a interviewing secret, right?
I feel like my world was
this-
changed when I learned that little skill, because we have our check boxes of things that we want to make sure, it's this, not this, and we're getting to the diagnosis before we can educate the patient and tell them exactly what they need to know, but it really doesn't help you gain that connection better, whereas you're saying by reflecting and like summarizing what someone says to you, like that's a huge nugget. People feel heard and seen, and that's a really good form of communication even.
Well, I think what you're kind of naming here is that open-ended questions really are about breadth, right? They give you a lot of width to what you're talking about, but not a lot of depth. And I mean, think about it as analogous to a swimming pool. If you have a very wide but shallow swimming pool, you don't learn to swim. All you learn to do is get comfortable in the water. But these reflections or summary statements or clarifying questions really are about the depth to it. And you can learn to swim in a very narrow pool that has enough depth for you to either sink or float.
This is fantastic. Is this what all psychologists do?
know,
They give you
what-
these
this
like
is cool.
really big picture, like
We
imaginary, this big picture imaginary things. You go, oh, that's great. I want to swim, not
great.
walk across the
No,
wading
deep-
pool.
Deep
Right.
conversation. I love this. Okay,
No, that's
keep
really
going.
good.
Keep going. Sorry.
So okay, so I think so. So the bottom line is these certain communication skills that somehow we haven't gotten, because these are typical motivational interviewing communication skills. We've gotten part of the motivational interviewing skills, but we haven't done these other ones. And learning the reflection and summary statements is clearly going to level us up in our ability to hang with patients and really be more psychosocial. So I think that's one clear outcome of the research. And so let's go now to like what you talked about for a minute, Sally, was you were saying, how do we get buy-in? Because buy-in's not just about understanding the patient and validating them. It's really getting into goal setting and things like that, right?
And can I tell you really quick, PTs think they need to massage people, use tools, cups, weird things to get people to buy in. And it's really interesting because it's like we have no confidence in our knowledge, and I think this goal setting and connecting things is important, but patient or PTs will sometimes say, oh, well, I'll use manual therapy on my patients to get them to buy in to my treatment or to come back for another treatment, which I think is way off base and weird.
Yeah.
So, like, doctors don't need to do that to get people to buy in. So I like this idea, like, I want you to talk about it too, because I do think there's money in this where you don't have to do all these techniques that might not be necessary. They're nice, but like, why do we need to do this to get buy-in? And how can this that you're about to talk to get the buy-in that PTs need to know?
Right.
So, yeah.
Yeah, it's a huge part about the buy-in piece. It helps the patient, because when patients come in, I often tell them, because they're coming in to see me, which can feel a little like that they're gonna analyze me and point out all the dark corners or things, and I immediately know who they are and I can read their mind or something like that. We get those
that's like us.
preconceived notions often.
Oh, that's
But
really
it's
funny.
just-
That's like the same as us. We like
Yeah.
know all your weaknesses. And
Yeah,
your
what
deficits,
muscles are
and
tight and where you're
mechanical,
not moving.
ninja people. Right.
Right, so then I try to kind of ease those preconceived notions right away by saying, hey, I'm not the expert on you. you're the expert on you and your own life and your own body, the way you are going about in the world, your beliefs, what have you. And that I'm not going to know that about you right away, and you're going to know what works best for you in your current context. So there's the idea, the psychological concept of self is context as well. And then there's kind of there are other layers of context that are around them. So that's kind of my frame of thinking about it. And then I say, well, I am trained to provide some interventions that may be helpful for you, but we're going to tinker around with them a little bit, see what will best fit for you. And then you're getting into that buy-in of like, out of all the things that we've talked about today, what is the most important one to focus on? What do you want help with first?
So how did PTs, when you, so this is really good because it's like your frame and all that. But when you were in the encounters watching PTs, like how did they set, because we're talking about setting goals, right? For patients. And we're going to say, I think, is that goal setting is the key to buy-in. Or a big piece to buy-in. We'll say it that way.
For sure.
Right. So what weren't they doing, or how can we improve goal setting in a way that gets more buy-in? Because I think a lot of PTs will say, hey, I don't have any trouble setting goals. I have functional goals. I have those all the time. They're SMART goals. We talk about all the time. So what is it that we're talking about exactly?
Well, I'll think about when I was out in the community seeing PTs is they propose all these exercise plans. And they're super helpful. They're meant to strengthen. They're meant to, connect pieces that are kind of disjointed, improve. But some of those things aren't exactly what the patients would see themselves doing.
Right.
And so it doesn't feel very functional or applicable to them.
So let me give
you're thinking about how can I modify or find some sort of movement that they find that they could see themselves doing or that they enjoy. And then asking them what are their values around movement and what would be some activities in their life that they want to get back to.
So let me give you some examples from today. Like today we were counseling some students and we were all kind of in there doing that, right? And so like today, like one of the encounters, the person said that they were in these Zoom calls all the time, and immediately then when the therapist gave them the exercises, they gave them all sitting, thinking, oh, this is really great because you can do them during your Zoom calls or between your Zoom calls for your hip. And they never once asked the patient or interacted with the patient in any way to ask them if that was their preference. Or if they even wanted to do those exercises in sitting or related to their Zoom calls. I mean, if you're in Zoom calls all day, the most thing you might want to do is not do more Zoom calls and not sit, right? And you could do many other different things like a yoga mat or take a walk or something like that, or you get outside or whatever it is, right? But that interaction never occurred in the encounter with the patient, right? And so that's really a bunch of assumptions there, and so there was never really explored like what the patient's preferences are or how it related to like their ultimate goal of not just like dealing with their pain, but what functional things or meaningful things they want to get back to. Is that kind of accurate? It's like they kind of focus in on an exercise program or something that they kind of connected in the narrative, but maybe didn't check back in with the patient. Is that what you saw in the encounters? Or
Yeah, somewhat. And I'll let Fred add in a little bit here as well. But I would see that you're doing all this great work gathering information at the beginning of your visit, right? Asking all these questions. What are you coming in for?
Right.
What were you doing before? Have you had any action?
Being discussed here is co-creating a plan, which is a category in the PCOF that focuses in when the plan of care is made, are we really respecting the patient's autonomy? And you can kind of see that in the behaviors that are described, especially describes options, pros and cons, uncertainties with decisions, patient understanding, preferences, and then finally identifying with their goals.
For clarifying what's most important to the patient. The PTs that did that were able to significantly increase the amount of activity that the patient was willing to do.
Oh, interesting.
And so we saw that increase, talking about this idea of buy-in. Buy-in is getting them to believe that they, A, have the ability to do it, and B, to have the desire to do it.
I love that. The ability to do it, right? Because that's like
Right.
really going to drive them to like work harder on their one rep
Right.
max or push harder
Right.
because they believe their bodies can
Right.
handle it, right?
And it's whether or not they actually have the actual ability, it's the belief in it, or the belief that they could get to it.
Right.
And for a lot of the patients that did have a PT ask about or confirm, hey, you're wanting to get back home, and that's one of these reasons why you need to improve your leg strength, or you need to get back to walking.
Yeah.
These are the patients that were clearly pushing themselves more in the appointment, that when asked about how things had gone, between the last session and this time, were the ones that were reporting the most effort in their work. And it seems like that was something that you could see a difference between PTs that did clarify or at least confirm it, that what was really important, or ask about what was really important, and the ones that didn't.
So that's something I think a lot of PTs would want to buy into. Like, as you said, who doesn't want patients that are pushing hard on the agenda that they're setting together? I mean, that's like a perfect world, right, for a PT life, right? And here you're giving this kind of solution for that. So, all right, well, those are a couple key points. Of course, there is others, but let's get back now. Let's go to this moment when
hot seat here.
Because some of this stuff we talked about, these are like some key things that we just randomly hit on.
And it's really cool, because when you guys are talking about like what's really important to hit on, I'm like, oh, I've been doing that, and I've been teaching the students that I've had around me, and of course I'm not perfect, and I'm very vulnerable with them and telling them like, I'm working on my summary statements at the end of the session, gathering like what are some big takeaways for you, and the patient has so they have more empowerment rather than me encouraging and rah-rah cheerleading them the whole time, because PTs have it's a great reputation, but they've got a reputation for being like really motivating, really like they want a good relationship with their patients. We're really, love exercise, love activity and all this, but at the same time, we think we're doing the best for the patient when we're really actually not evoking their own desire to move and their own wishes in what their life should look like. We love to say, here are your exercises, these are going to help you, I know, and let me educate you on your body. And it's like we fire hose our patients rather than actually evoking like what's important to you and how many of these do you think you can do at home, rather than saying here's 3 sets of 10, do these exercises. Instead saying like, what would make you more successful at your home with some of these exercises to get you back to doing X, Y, or Z. Then they tell you, the patients will tell you most of the time what they want. Sometimes they'll tell you even what's wrong with them. They may not know their diagnosis, but they'll tell you the things that are important to them if you listen. And then that's where I think the reflection statements, the summary statements are important. So, gosh, I'm so good at open-ended questions, but making the statements and actually like evoking this response out of the patient was so hard for me. Like I could not make a statement because I felt so awkward sitting there.
So this is great reveal, right?
Man,
it is. I think it's super hard too. When I first learned how to do reflections, I found that incredibly difficult and scary.
Yes.
Right. But before we get into like your learning process, what do you think what do you think the payoff is? Because now we've been doing it for a while, and you and I have been working together, mentoring with these ACL reconstruction patients. So we're not even talking about chronic pain or whatever. Mm-hmm. These are patients that have like typical problems we see every day, right? And in them, how much of this applied?
All of it.
Yeah, it was surprising, right?
It's amazing.
Like we're now thinking and wondering like quadriceps avoidance or the lack of a quadricep return could even be strongly linked to psychosocial approaches 100%, to care, because we're really missing them pushing them through, like motivating them enough to really work hard to get that quadriceps back, even when it seems like they are working hard. Just getting the right muscles and the right kind of effort into that rehab, can make a big difference, and that's what we're learning, right? Yeah. And so what we're doing, it seems like you're coming around to, and me too, is like this idea that psychosocial care is biomedical care. Yes. Because it's 100%. Causing hypertrophy, it's causing higher, kind of stretching dosages, much more effort and just bigger dosages in general in terms of achieving these kind of responses that we're getting. Mm-hmm. So that's the benefit. So it's like much bigger than we imagined starting off, because I think starting off I just thought, well, better psychosocial care will kind of help me align with patients and understand what their needs are and things like that. But really this buy-in thing is compliance, it's dosage, it's better, physical health basically. Yeah. And so it's as powerful as an exercise program. right?
100%.
Or more maybe, right? And so let's dial back. So that's like the
Yeah, sorry, that was a lot, and I feel like I spoke so quickly,
No.
but it's just, it's all really cool and enlightening, and I love any chance to get better. But what was your, I guess,
So let's go
question?
back. Like what happened when you, like, as you had to go through this acceptance part, I think, of like where you were at,
Yeah.
right, first, and then you started in on learning skills, and like how did you see all that unraveling for you, and what kind of feedback did you get from everybody that was valuable to you?
Yeah, so first of all, it's really intimidating being evaluated, because you think as a therapist, you're like, I'm knowledgeable, I know what to do, I get most of my patients better, I felt really strong in my ability to connect with people. But I think what I was missing and what got brought up is just my, like, missing the mark on, so I'll just give an example, because stories sometimes are easier than giving too much, like, definition, whatever,
Or
academic
Go.
background.
Yeah, yeah.
But
Yep.
so I had an ACL patient who's trying to get back to rock climbing, and I've been working with him already for like 2.5 months maybe, and prior to his surgery, so I'd known him for a while, and I had never gotten to the depth that I did when I asked him, so what are your biggest takeaways from our session today? I'd never asked him this before, and so he told me, it was really discouraging. And I'd seen him perform well, like he was learning, he was activating his quad, he was doing all these cool things that we had never really practiced before. And I had to sit with him in that and say, first I didn't know what to say. It was like, he just told me that he's discouraged. He let me in on something that I didn't know. And so I tried to summarize. So it sounds like you didn't perform as well as you would have liked to. And he said, yeah, I didn't realize how much weaker I was on my surgical leg than my other leg.
Can I just, because I was
Yeah,
there, so
yeah,
I remember
yeah,
this
yeah,
case.
jump
This
in.
was super, because at the time I remember myself, and
Yeah.
I think you too,
Yeah.
we were all psyched
Yes.
because we have the protocol in front of us and we know
yeah.
where he should be, and we thought he's killing it.
Yeah.
This guy's killing it. He's like ahead. We're
Yeah,
great therapists. We're doing the right thing. And you had the
Totally.
agenda totally down.
Yeah.
And then you're giving the after visit summary. You're expecting him to say, you guys are amazing.
This is awesome.
And he says,
I'm really discouraged.
and we're just like,
What?
bam.
Like, at first I wanted to say, no, you did great. That was awesome. Of course, that, like, we have this writing response of, like, we want to boost them because it's hard to sit in the valley that they're in right then. And so instead of trying to correct what I'm learning or to have that writing response, is you can summarize and then you can even ask a follow-up question. So, okay, so you didn't perform like you expected to, like, what does that tell you about your leg? It's like, it tells me we still have a really long way to go, or we still have more to go on my strength. And so it gives insight then into, like, okay, so he says he needs more strength. That's what we can focus on next time. So the patients, again, will tell you kind of what they want to work on, but I don't know what other...
So much happening here and what JD's experiencing, but let's identify what the behaviors that the PCOF identified as closure. Notice that they ask for affirmation that what the patient's actually learning and experiencing rather than just assuming that what you said is what they took in. Second piece that is JD's pausing and accepting what the patient says, which we'll discuss in a separate video. Let's get back to the conversation.
Well, no, I really like that
but-
because one of the things that has happened in our interactions, you now almost do no cheerleading with patients.
It's like zero.
Zero,
It's actually amazing because
and
I
you don't-
have so
and you
much
don't-
more energy.
Which is really funny.
throughout
You
the
don't
day.
talk to patients about their social
Yeah.
life. Really.
Yeah, oh yeah.
Because
I
you
do that all
don't,
the
but
time.
mostly because you don't have time.
Yeah.
So you don't ask them like what their favorite songs are,
Yeah.
what they did last night or something like that,
Yeah.
because you're so focused on interacting with them at a psychosocial level that takes all the time up. And it's not that you're not interested in them, but we have more work to do on
Yeah.
their disease
Yeah.
rather than just, okay, we've got the exercises done, so we just need to entertain them.
Right.
So it's shifted
Yeah.
from like entertainment to really kind of understanding more about what they're going through.
Right.
Right, and this is a great case because he was discouraged, and then I remember that what happened in that case is that you brought out like, okay, well, we wondered because we had kind of done so much with him and he was making good progress. turn to, well, how could he see himself as so bad off? Or like, well, where do you want to be? Like, what
Yeah.
are your goals? And this
Yeah.
is that buy-in part
Yes.
that you talked about. And then that's when it kind of blew us away, right? Because he's this kind of skinny guy.
Yeah.
And he didn't
Yeah.
seem so like, like all in, like, he's going to kill it and like be the tier one
Yeah,
basketball center champion
Yeah,
or whatever
yeah,
it was. He's
yeah.
just kind of, seems like an average kind of low key guy. And then
Yeah.
what did he throw down?
Yeah, well, so he helps people climb, and so like he wants to be able to like stop against the wall on a dime, or to be able to help people rappel, or he's like champion level rock climber, boulderer, so he wants to be able to get up to the top of this wall and jump off this wall, and so like
Did he say like 10 feet? He wants to be
Yeah,
able to
like,
drop 10 feet and drop on his injured and land
Yeah.
only on his injured leg.
yeah, and land primarily on that leg. So I'm like, okay, wow. So you are not where you want to be at all, because
That's like a roof.
Like, holy
That's like jumping off a roof,
That's like
right?
crazy.
Right.
So yeah. So that was cool, because like you're talking about the goals piece. If we want to get buy-in, we're not going to massage his leg to get him to feel like PT is working for him. Like, we want him to feel like we're going to set something up to get you to your goal. Like, your goal is the piece that we focus on to get you to buy into like our time together. That really connects, PT to your life, not whatever interventions I can do. It's all about you. So it kind of flips the mold from like, my agenda for you is this. Instead, it's like, okay, what's your agenda for you? How can we help facilitate that? Like, how can we create a 20-foot wall for you? I don't know that I want to do that in sessions, but like, how can
Might
we
be a little extreme.
Yeah, like how can we recreate this environment for you so you're getting value out of PT, not just coming and doing leg extensions on a machine that may or may not get you to where you want to be functionally.
But I think that started this dynamic with him, right? That every session now was about, kind of checking in with him about how his challenges were and what he was going through in terms of his mind, and how he was connecting up with, his home exercise program, and how that was, he was feeling the strength gains and the recruitment that he needed to, and his performance during the home exercises, and how that was connected to his climbing activities.
Right.
And it started this whole dynamic where the entire session you were kind of in this kind of semi-head game, semi-actually what's his behavior, and how that's all matching up.
Yeah.
You know what I mean? And so just encouragement fell away, and it was replaced by all of these reflective statements and these kind of identification of like, what are you getting now? Like, what do you feel now? How's this training affecting you now? Do you feel better about that, or you feel like you're really getting that strength you need to jump off of that wall, and all of that stuff came rolling in, and now you had like this kind of rich profile or narrative to kind of interact with that patient on.
And it helps us create a better exercise program that he might be more compliant to, like outside of PT. Sometimes you give people stuff to do, they don't want to go do it. Just like I'm sure in your sessions with folks, like if you give them tools that they're not going to be successful doing, they're probably not going to practice them. So that's why it's important to kind of tune into like, what would make you more successful with this, or how can we kind of make this fit into your life a little bit better. So anyway.
Well, it sounds like this person really also is highlighting the fact that the gap between expectation and reality is the size of disappointment.
Yeah.
Right, and the farther those two things sit apart from one another, the harder it is for us to motivate. And in many ways, we sometimes miss the mark because we have our expectation and they have their expectation.
Right.
And we might get their reality close to our expectation and feel really good about it. And totally miss where their expectations were. And they're not going to come back.
Right. That was actually something really profound you said to me, is like, why do they feel this way? And it's because they weren't meeting their expectation. And we had to talk about expectation. I remember in the biomechanics lab, and I was like, oh, that's why. So I'm thinking like, oh, he doesn't feel strong enough. He doesn't feel this. It's like, no, he wasn't meeting his own expectation.
And the therapy was still awesome.
Yeah.
Do you know what I mean? Like
exactly.
on the one hand, it was still awesome. It just wasn't like connected to the person.
So something that the research pointed out is that closure was almost never used by therapists. And in fact, the providers with strong biosocial beliefs only used closure items about 35% of the time. So as a result of this research, we decided to try these different phrases throughout the visit, which kind of give us this look at what the patient's actually taking in. And I can't emphasize enough how valuable it's been in really understanding where the patients are at and helping redirect our goals and treatment. So I thought we'd end today with some commentary by Fred and Sally on this topic.
Well, I'll speak first here, but there's this phenomena that happens, especially in more kind of traditional psychotherapy, that we call a doorknob confessional, where people will disclose things as they're heading out the door.
Doorknob confessional.
It's the oh, by the way,
That's
Right.
right.
this other thing happened.
Yeah.
And you're just
Right.
like,
That's so funny.
why'd you do that right at
Right.
the end of your visit?
I know. I'm with
Right.
you. That's happened to me before too. I'm like, oh, that would have been helpful to know that you did this or that this happened.
Right.
But okay, cool. Anyway, go on.
But it lends perfectly to this idea that getting at least a summary at the end of the appointment, where we're wrapping up, where we're doing that closure piece, gives them an opportunity to disclose that then, and for us to either address it now or make a plan to address in the future, without kind of the randomness of, oh, I'm going to do it as I've already stood up, I'm getting out, and then, oh yeah, I forgot to tell you,
Right.
this just happened to me.
Yeah.
So I think for a lot of people, it's just giving them that permission to then say, well, is there anything else? Right?
Right.
But it's also about understanding, right? I think the reality is, and even for in psychology and therapy, we oftentimes say things that we think are brilliant, that we feel like the conversation was really well structured, that it felt like we got this richness and things.
I've heard you, Fred. You are brilliant. Whether they think so or not.
I appreciate it.
We have those moments too where like, I am killing it. Like, I made this great interpretation. It's a nugget, I'm telling you.
They got all of that.
Right.
They got it all.
But they may not have understood any of it. They
Right.
may have got it
Yeah.
totally differently than I
Right.
Hit
expected
at the
it.
wrong time too. And
Right.
Yeah.
Right,
I mean,
like-
even things like this piece of closure, asking for questions about today's topics and using that teach back.
The main categories discussed here were gathering information, co-creating a plan, and closure. Some that weren't discussed were behavior change and sharing information. So we've identified essential communication skills that therapists do and don't use, and we've connected these psychosocial skills to both biomedical beliefs and to stronger psychosocial beliefs. We believe that these communication skills could really make a difference in patient outcomes, and therefore we're committed to continuing this narrative in future YouTube videos. See you soon.